Good afternoon and welcome. Thank you for joining us today for our training, Opiate Use Disorder Management in Nursing Facilities, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. And now, I am happy to introduce our presenter, Dr. Jen Azen. Dr. Azen is a general internist who has practiced in both the primary care and post-acute care settings. Her primary care practice is focused on geriatric patients. She provides in-home visits to medically fragile patients in private homes, adult family homes, and assisted living. She currently works in post-acute care with Harborview Medical Center's Bed Readiness Program, where she cares for patients with substance use disorder. I'll now turn it over to Dr. Azen to begin the presentation.
Thank you, Nikki. Happy to be here. Hi, everyone. I have one financial disclosure. My husband is a home infusion pharmacist for CVS, and he participates in an employee stock plan, but does not dispense any of the medications I will be discussing today. And this is my little dog, Theo. He turned 2 today. Today is his birthday. You see him throughout my lectures. So learning objectives for today, we really want to review the epidemiology of opiate use disorder, diagnostic criteria, medications, and then the logistics around buprenorphine, methadone, and naltrexone, specifically in skilled nursing environments. I also will review behavioral treatments for opiate use disorder and urine drug testing that can be done in evaluating patients with opiate use disorder. So quickly going to review epidemiology of substance use disorder and opiate use disorder. It's not news to anyone really that we are in the midst of a pandemic with regard to overdose deaths, and we saw a 40% increase between 2019 and 2021, and that's continuing to rise, specifically because of synthetic opiates like fentanyl have now come to the market and are much more powerful and at much higher risk of causing an overdose death. And in our populations, which are typically greater than 65, but not always, we're still seeing a rise in overdose deaths. In particular, men are starting to have quite a bit of a spike in overdose deaths, but women are also noticing an increase. So it is coming to our facilities and something that we really need to understand how to manage. I wanted to also review the overdose deaths in the disparities with race and ethnicity. So African Americans and American Indians and Alaska Natives are seeing a much increased spike in overdose deaths, and also Caucasians. Really, one of the things that we think is going on is that there is less access to treatment. And in particular, Black Americans are less likely to be prescribed buprenorphine. And 87% of people who use opiates living in the United States are not enrolled in treatment. And many of these people will say that they're interested in treatment, not all of them, but in the people that are interested in treatment, some really have a lot of barriers to accessing treatment. In a skilled nursing environment, when you're dealing with a patient with potential opiate use disorder versus opiate dependence and chronic pain management, it's sometimes really confusing to understand exactly what their opiate use is from. So are they needing treatment for opiate use disorder, or do they simply have some opiate dependence? And being able to classify that is really key. And I know in my facilities, a lot of times that is done by the admissions nurse putting down diagnoses and that sort of thing. And so when we're assessing patients and trying to determine what medication is right for them, really returning to this grid that looks at the DSM criteria for opiate use versus opiate use disorder versus dependence is key. And I think the one thing that I want to point out that's different than other substances is that patients on chronic opiates for chronic pain syndromes will develop a pharmacologic dependence on the medications. So that last column does not count if the patient is prescribed opiates and is taking them as prescribed. So really, if somebody is on opiates for 15 years for their chronic back pain, but they haven't had this loss of control, they haven't had social impairments related to their to their opiates, and they haven't had any health impairments, they don't have an opiate use disorder. They simply have opiate dependence. Contrast that to somebody who's had surgery and they're being admitted and they're on short-term opiates. They're using opiates, so it's opiate use, but it is not at this point opiate dependence and typically isn't an opiate use disorder. So patients with residents with opiate use disorder have this loss of control. They're looking for increased amounts. They're very fixated on the medication or the opiate, and they spend a lot of time, focusing on opiates. So we will see some of these behaviors in perhaps patients that are maybe at the cart at every PRN dosing on the dot and are asking about it and constantly asking for dose escalations. That's demonstrating there may be a bigger issue in the background. And then looking at social impairments. And if their opiate use is causing issues in their family and their work life, if they stop doing activities because of the opiate use, then we're moving into an opiate use disorder. And then continued use in hazardous situations. So if they even had an unintentional overdose and were admitted to the hospital, say with hypercarbic respiratory failure, that's demonstrating that the opiates are no longer safe. But if they're demanding that they continue to use them, then we're probably moving into an opiate use disorder category. So thinking about doing an assessment with the patients, asking them about these issues, and then determining if they have a use disorder, and then if it's mild, moderate, or severe. That's how it should be documented in the diagnosis codes. So opiate use disorder versus opiate dependence without evidence of disordered use. Chronic pain syndromes, when documenting those in the diagnosis codes, we really want to describe the location of their chronic pain. So it's better to use chronic back pain versus just a simple chronic pain syndrome. But as many of you know, some patients have pain everywhere, in which case sometimes chronic pain syndrome is going to be the most descriptive diagnosis code. And then opiate use, if they're taking opiates but they don't have any dependence, you may want to put in a diagnosis code as opiate use. But please avoid any of the diagnosis codes that state abuse. We're really trying to reframe this disease as a disease process, and abuse is a term that suggests that the patient has kind of a moral failing. So using use disorder in documenting a severity is a better way to go. If they're currently on a treatment program, so if they're on a medication-assisted treatment program that I'm about to describe, then you would put opiate use disorder in early remission if it's a new medication for them. If it's a sustained medication, you would put in sustained remission. So there are 3 medications that are FDA approved for opiate use disorder. I'm going to focus a lot today on buprenorphine because that's the medication that's going to be the most available in a skilled nursing environment. It's in multiple formulations, and new as of January or February, any provider with a DEA license can now prescribe buprenorphine for both pain and for opiate use disorder. A year ago, I would have been telling you that the DEA providers without an X waiver can only prescribe buprenorphine for pain, but not for opiate use disorder. But that stipulation within the DEA code has been taken away. So all providers can prescribe it. And any pharmacy can dispense buprenorphine. So in a skilled nursing environment, there's all of those barriers that we previously had with buprenorphine. So I think many providers that work in skilled nursing didn't really see the utility of getting X waivered. Some did, and that was great, but there were many facilities in which there wasn't an X waivered provider that could prescribe buprenorphine. That has gone away. So sometimes educating your providers, I think many know this because they need to now do substance use training in order to maintain their DEA license. Methadone can only be dispensed in an opiate treatment program. So even if the patient, the resident is in a skilled nursing environment, the dispensing must come from an opiate treatment program. So what we call a methadone clinic in the general public. It cannot be sent from your central pharmacy. It's got a lot of DEA restrictions regarding its use. IM naltrexone is the least used medication for opiate use disorder, and it can be prescribed by any provider, and pharmacies can dispense it, although typically it's not a medication that pharmacies carry, and it's often carried in more specialty pharmacies. One of the things I like to mention is the effectiveness for treatment of opiate use disorder. We think of aspirin in a patient that's had a heart attack as being very much standard of care. It takes 42 patients to treat with aspirin that have had a heart attack to prevent another heart attack, where it only takes 3 residents to give buprenorphine to prevent death and 2 to give methadone to prevent the death. So really powerful medications in preventing death, which is what persuaded me to get my X waiver several years ago. So reviewing the mechanism of action with these medications is really understanding this curve and kind of understanding the mu receptor. Mu receptors are what are in the brain that sense pain. Full opiate agonist, methadone being one, but oxycodone, hydrocodone, hydromorphone, all the opiate pain medications that we give patients or we give residents, and then ones that people find on the street, like fentanyl, heroin, all of these have the same mechanism of action. They stimulate the mu receptor fully. So if you can see here that the methadone is fully stimulating the mu receptor. Also, there is kind of a you can continue to give, and you will get more and more mu receptor stimulation, but also you'll start getting respiratory depression. Buprenorphine is a really interesting medication from a pharmacology standpoint because it only partially stimulates the mu receptor. So it has a ceiling effect. So you can give more and more and more. And at some point, it doesn't do more. It just has then fully saturated the mu receptors, and you can't get additional effect, which has some benefit. It keeps people from having respiratory suppression, which is what causes overdose deaths. And also because it binds more tightly to the mu receptor, it will block some of these full mu agonists, which is really key in preventing overdoses. And naltrexone is a full agonist. So naltrexone and naloxone, which we all know of as Narcan, completely blocks the mu receptor. And because of that, really no other medication, buprenorphine or methadone, can overcome naloxone. So starting with buprenorphine, let's look at the formulation. So there's tablets, films, and then an injection. What you're typically going to see in a skilled nursing environment is likely the tablets, but sometimes you'll see the films. The tablets are typically cheaper, and most insurance companies have a preference. Specifically, Medicaids will have a preference for tablets over the films, but you can see both. Either way, both of these medications need to be dissolved under the tongue. So they are a dual formulation. They have buprenorphine and they have naloxone, which is Narcan. So when absorbed under the tongue, the buprenorphine is fully bioavailable. So it gets into the system and it works. If swallowed, it's less bioavailable. So the buprenorphine is less effective. Probably about 50% will get into the bloodstream compared to if it's taken under the tongue. The problem is if you swallow this pill, the buprenorphine is less effective, but the naloxone that's in it is effective. So you will be giving an opiate blocker and can induce withdrawal. So it's super important that it is not swallowed, and really educating the resident and educating the nurses regarding this is highly important when delivering buprenorphine in any type of environment. I think mostly in outpatient settings, we can educate patients and they know how to take it. But when nurses are providing the medication during administration, sometimes because it's a tablet, it goes in with the rest of the tablets and they just hand all of the medications to the patient. If the resident takes those medications, they can have an adverse reaction. So I typically recommend giving it separately from the other meds. So all the meds first, and then the resident gets the Suboxone after they have swallowed the first meds. It takes about 15 minutes for it to fully dissolve. The injection of buprenorphine is called Sublocade and is available also through typically specialty pharmacies. There is a buprenorphine tablet that doesn't have the naloxone in it. It's called Subutex, and some residents will state that this is the only one they can take, and if they come with it, it's still taken under the tongue because it's more bioavailable. So I've already discussed a lot of this. You want to really separate it from the rest of the pills so that there is no confusion. And then the other thing that I do recommend is that residents rinse with water or brush their teeth or use mouthwash about 30 minutes after administration of the buprenorphine, because it's quite acidic and can cause tooth decay at a faster rate. Sublocade, if given in a skilled nursing environment, will require some additional nurse training. So a nurse, one or two nurses would need to be trained at a center that does it. You have to work with the REMS pharmacy. So typically long-term care pharmacies will not have a REMS certification for Sublocade, but you may be able to find a local specialty pharmacy willing to deliver. The other option, really, if a resident is on Sublocade, is that they go back to the clinic where they receive Sublocade once a month and get their injection. It's probably the simplest way to go. So when residents are having acute pain, say they had a surgery, you can actually give full mu agonist. My preferred one is hydromorphone or Dilaudid, to be given sometimes at a little higher dose, and it will competitively bind with the buprenorphine and provide some additional pain control. We've had really good success managing postoperative pain this way. And then you still have to worry about constipation. If a resident refuses multiple doses, there's a risk they may be ready to start using again. And so that's something to certainly discuss with the provider, and maybe considering urine tox screening to help guide the resident in their recovery process. Next, I'll quickly review methadone. It must be dispensed by an opiate treatment program, which I've already discussed. It's in liquid formulation when dispensed by opiate treatment programs, and partnering with a local program is possible. It can be given to residents in skilled nursing environments. Often in my particular center, we have an opiate treatment program deliver 1 week's worth of methadone, and then the residents get the methadone from the nurse on the cart. There's a chain of custody documentation that was formulated so that it satisfies DEA regulations on the opiate treatment side. And then the nurse typically will document both in a book for the for the opiate treatment program, as well as the typical controlled substances book, where there's a 2-nurse documentation that the resident has received the medication. And then any reported cravings or concerns really need to be communicated with the clinic, because it's their job to manage it. And quickly, naltrexone as an injection, if you have a resident who's admitting who's on naltrexone and they're due for their dose of, like, say 10 days into their stay, and you're unable to find a pharmacy that can prescribe, that can dispense the naltrexone, you can move to an oral naltrexone at 50 milligrams daily, as kind of a placeholder, for so to speak, until the resident's able to get in with their typical place where they receive the naltrexone, or unless you're able to find a pharmacy that can provide it. It must be given every 30 days. And if you anticipate a procedure like a surgery, it needs to be held, they cannot receive naltrexone IM for 30 days prior to a surgery. So you switch to the oral version. And the reason you do that is because opiates are absolutely not effective against naltrexone. So behavioral treatments, really, medication is the foundation, but there are also great treatments with mutual support. Narcotics Anonymous is available online, and sometimes willing to come into facilities. I've discussed Smart Recovery is an alternative mutual support group that does not have as much of a religious base to it. So some residents really prefer a non-religious option, and that's an option for them. And there's many online meetings. Sober living may be a consideration at discharge, and inpatient treatment, if indicated, can continue these medication-assisted treatments. So substance use testing, urine is really the best way to go. Not all urine tests are going to pick up all of these treatment options. So when choosing a urine drug screen, either through the lab, or maybe if the facility wants to buy point of care testing, it's really important to figure out what is on the urine drug screen. So buprenorphine is not a standard urine drug screen assay. So you need to find one that includes buprenorphine and also includes fentanyl, which is often missing in our typical urine drug screens. They don't pick up the synthetic opiates. Methadone is also typically tested separately. So really, to find the right urine drug screen, you want one with both methadone, fentanyl, opiates, and buprenorphine. So treatment is really a life-saving intervention. And so if residents are discussing wanting to wean off treatment, it's really important to talk to them about the longevity of treatment. Usually 1 to 3 years is needed before residents can really stabilize. And working with a resident on doing a taper is something that really a specialist should be involved in. So getting them involved with somebody who is used to managing opiate use disorder and really just determining what's best in their treatment is important. So I typically encourage residents in my skilled nursing facility to stay on treatment until they're out in their typical setting and know they're stable, and then start to reduce. You always want to discharge with Narcan in hand, because it can save lives. And you want to continue the opiate use treatment in the outpatient setting at discharge. So really coordinating that at discharge is important. And when you're assessing a patient for their treatment, you really want to ask about withdrawal and cravings, and not about pain. You're not managing pain, you're managing their opiate use disorder. And opiate treatments such as buprenorphine should be continued in the perioperative state. So treatment is effective. Documenting the diagnosis is important to figure out how you're using these medications and which medications you should be using. Assessing opiate use disorder is different than assessing pain, and barriers in the nursing facilities are really gone at this point. So it's about education and getting residents who are on buprenorphine in a post-acute environment. And then barriers to methadone still exist, but can be navigated.